Welcome, Dr. Gupta. How are you doing out in Cleveland right now?
Thanks, Gina. I'm good. How are you?
Pretty good, staying safe. How have you been doing really in terms of the COVID-19 pandemic? What have you been experiencing out there in your practice?
Yeah, that's a very good question in these uncertain times, and every day is a new day, and we have really tried to adapt our practice based on the ongoing challenges. I can speak for my own practice. I tried to prep my clinic few days ahead of um the visits to see what visits can be converted to virtual visits. We have that facility at our institution where we can have a virtual meeting with the patient, a face-to-face meeting, and we also are doing a lot of phone visits. Some new consults, if they can be done virtually, I'm trying to do that, especially patients who are coming just for second opinions, so they don't have to make the trip, and connecting more with their local oncologists and making the plans. So to minimize the points of contact for the patients. And those patients who need to come in for their treatment, which cannot be delayed, we are trying to do that virtually as well and have them just go to chemotherapy infusion.
And so how are some of those virtual meetings going? Has it been a receptive process among your patients? There been any challenges that are worth mentioning?
Well, sometimes there are some technical challenges, and then we resort to the good old phone call discussion. But patients really like it, and I think they prefer to see the doctor's face or the provider's face, and it gives them some reassurance. So we try to do that. And some of them want to do FaceTime if the virtual app doesn't work, which we have been also doing at times.
Right. Now, obviously, things related to COVID are changing daily, sometimes even hourly at this point. What have been the most recent changes that you've seen kind of come through in your practice at Cleveland?
I think the more changes we are seeing is the number of admissions that has been increasing, and our institution is really doing a great job with keeping us updated on a day-to-day basis. So we know where the hospital capacity is in terms of admissions, and so to serve that purpose, we are trying to make sure that our clinics are well planned, and patients who have more risks than benefits of getting any treatment, I'm trying to withhold their treatment or defer it to avoid any treatment related admissions, which would be really not in their best interests. So that's one thing. And secondly, we are minimizing the traffic of visitors with the patients unless absolutely needed. All the patients and the visitors and the providers, we are screened at the entry point every day. There's a temperature check. So we are trying to screen as much as possible. And when I'm in room with the patient, I'm using masks to, have that barrier protection.
Obviously, there's been a lot of news surrounding shortages across different hospitals in terms of face masks, gloves, and any kind of really sanitizing equipment. How have you been handling all of that?
Fortunately, as far as using a surgical mask, we don't have a shortage, but the N95 and other protective gear is only reserved for people taking care of patients in the ICUs. But yeah, there is a shortage, which is really an unfortunate thing, and we're trying to be judicious with the use.
Of course, of course. So, have you had to experience any of your patients being COVID-19 positive so far?
So far, I've had a couple of patients who were admitted to a local hospital with pneumonia-like symptoms and still trying to figure out if it is related to COVID-19 or their disease. And that's really a challenge now that for every differential diagnosis, the COVID-19 comes as a possible and the top priority now, especially for patients on immunotherapy, where it's really important now to see if it's related to the treatment or to COVID. And that is a challenging aspect of our patient population.
That's an excellent point. Are there any kind of strategies that are being looked at right now to try to identify whether it is due to the immunotherapy or potentially related to COVID-19?
So I think patients who are getting admitted, they are being tested, they are for the COVID-19, and I think empirically they're being treated with steroids if there's a slight suspicion of it being from immunotherapy, which possibly can't hurt if they're COVID positive also.
Thank you. Thank you. So now you, of course, treat patients across GU cancers, and you talked about kind of modifying some of their treatments because of wanting to make sure that they're not being put at further risk for this. So what are examples of some of the treatments you've been modifying and approaches you've been taking with them?
Yeah, so some of the patients with metastatic kidney cancer or bladder cancer, for example, who are on immunotherapy and who've had a stable disease or a response in the past and continuing to do well, I am deferring their treatment because, you know, there's data out there that even if immunotherapy is withheld for a couple of doses, as we do, if they were to have an immune-related adverse event, it's not going to harm them. And this is, of course, after having a discussion with the patient over the risks and benefits. So those are some patients that I'm deferring the treatments and checking on them. And patients who are on salvage chemotherapy and are frail and at risk for hospitalizations if they were to get second or third line chemotherapy, for example, for prostate cancer, I'm withholding that as well and continuing supportive care with patients being in agreement of that.
So is it also a point in time where are you experiencing a lot of patients that for so long, they were very excited to get immunotherapy and really wanted that versus some of the other drugs that are available? Is it almost kind of a 180 approach now because they're hearing how immunotherapy could potentially compromise their immune system?
Yeah, I think patients are also cautious. You know, they want to withhold treatment if they don't have to. In fact, some of our patients called us themselves and said, we don't even want to do any blood work or anything till this COVID-19 settles down. And yeah, there's a lot of, you know, news out there, and it would be good to get more information. And the data that came out recently in the Lancet that patients who were on treatment did worse in China, although we don't know many details of what that treatment consisted of. Those patients, majority were lung cancer patients. So I'm really weighing the risks and benefits. And in prostate cancer, patients who are just on Lupron or oral hormonal agents, we are not having them come in. And I have a long discussion with them. It's okay to delay the Lupron if need be. And sometimes those are the tougher patient population to convince to delay the Lupron, although, you know, many patients always want to delay Lupron because of the side effects.
Right.
So it's just a balanced discussion. And I think patients are coming around to understanding the risks and benefits. And the fact that we are checking on them more than we usually do in between visits is also giving them reassurance.
Do you find that they also are really educating themselves and kind of staying on top of this? And they've all, for a while, it seems that they're obviously not just educating themselves on their cancer, but really how to kind of protect themselves during this process.
Yeah, I think a lot of patients are doing that. And, you know, I think it's most challenging for patients we are trying to treat with a curative intent, where the treatment does include surgery in the near future, and decisions about that are tougher, you know, if the surgery is going to be delayed. So I think patients understand the risks and benefits. And in my experience so far, patients are not pushing to be treated. I think most of them are understanding that this is a bigger risk in their setting if the treatment were to have more side effects requiring hospitalization.
Great. Now, in terms of, obviously, there's been a lot of clinical trials that have now had to be put on hold, or they're not going to be recruiting new patients. How have you really seen the clinical trial aspect of oncology really kind of take a halt during this pandemic?
Yeah, so in our institution, we haven't halted new patient enrollment, but we are just using a very common sense approach to it. For example, if a trial offers standard of care treatment plus X, we are not enrolling on that study. And we are propagating for standard of care treatment closer to home if they are coming from a long distance or at our institution. For patients who are already on the trial, we are minimizing their study-related visits as long as they can get labs and scans done locally, and then we do a virtual visit. So in that regard, we are letting the sponsors know of our plan and shipping the drug to the patients if it's oral medication. So obviously a lot of anticipated deviations here, and our research leadership has enforced this, that patient safety first, and we will take care of the deviations per protocol. And I would say that a lot of sponsors are very proactive also. In fact, some companies have said it's okay, do not enroll patients until end of April, because they want to monitor the situation on their end too. Because, if patients are getting into trouble because of COVID and being on the active treatment, I think it's a risk, not just for the patient, but also for the study in general.
That's a great point. Just kind of, there's been a lot of chatter on Twitter, for example, on different reports and trends coming out. Has there anything that you've seen kind of come across that has really either surprised you or you think we need to start paying more attention to in terms of kind of statistics and trends?
I think what we are seeing, at least in our state and institution, that the inpatient hospital admissions are on the rise. And I think that goes with the trends that the peak is expected to be in April and May. And so it's not unexpected totally, but I think the number of patients requiring ICU stays, those numbers are pretty high, and we want to be well equipped with, triaging so that we are not using beds for patients who don't really need to be admitted.
Of course. Now, kind of looking at the broad scheme of things, what advice can you offer to healthcare professionals who are really trying to navigate, even potentially for those who are early on in their career and are kind of opening the door into all of this? What advice do you have for them?
Yeah, I think the advice here is patient safety first and do no harm. I think that's, as oncologists, we have to balance out the risks and benefits of keeping patients on track with their treatment. But at the same time, that one hospital admission in a frail patient amid this COVID-19 crisis can be fatal, and we have to wait according to what setting the patient is in. If we are giving a treatment that was going to improve their survival for a few weeks or a couple of months, and is it okay to hold a cycle of treatment? And that is the discussion they need to have. And I'm not by any means saying that we should delay curative treatments. I just saw a testicular cancer patient last week, and we started him on the treatment right away, knowing the risks and benefits, but we have to triage accordingly. And this is not the standard time right now to do everything in an ideal way. So we have to learn how to adapt to the situation and do what is best for our patients. Absolutely. And ideally, we would like to do a lot of things in a different way, but we really need to learn how to do what we can for which patients we can really at this point.
Absolutely. Now, beyond COVID, what are some other updates perhaps in GU cancers that you think are really important and we should be paying attention to right now?
I think the neoadjuvant bladder cancer space was really an important topic at GU ASCO, and I'm happy to report that we got 2 Department of Defense grants looking at immunotherapy resistance and response biomarkers. So we're very excited about that. We are looking at the maintenance, the Javelin 100 trial that was positive, and looking forward to seeing what's planned for the ASCO annual meeting with regards to that. Apart from that, research trials, as the pace may be slowed down, so we have to keep working with that. And I think the progress will still keep being made in different ways.
I just saw this morning about the tivozanib application that was resubmitted for renal cell carcinoma. Do you have any kind of thoughts on the data that support that application?
I think that's interesting. I believe they had some updates to the overall survival data, and it would be really interesting to see what it is at ASCO.
Definitely.
Yeah, that's a good option.
Yes. And you brought up ASCO, and obviously now we know that that meeting is going to be going virtual this year. So do you have any kind of thoughts on how we're, now starting to migrate all of these larger oncology meetings that we've gone to so frequently and so often, now kind of moving into a virtual format?
Yeah, it will be a big change for everybody around the world. And I think knowing the ASCO's commitment to its mission, it's still going to be a great meeting. And like I said, it's not an ideal time, and nothing is what we would want ideally, but I think the science is still great and we can share it virtually. And perhaps this may change the format moving forward a little bit.
That's great. Thank you so much. Dr. Gupta, is there anything else that you would like to share?
No, thanks, Gina. Stay safe and get the news out there for everybody to stay safe and do the best they can. Thank you.
Absolutely. Thank you so much.
Take care. Bye-bye.
Bye.